Each episode, we're going to dive into evidence-based strategies, cutting-edge research, and real-world insights to help you elevate your practice and empower your clients. Okay, so welcome to the Rehab Blueprint Podcast. This is episode 1. This is our first episode. Sitting here with two legends. We have Luke from the Rehab Professionals, and we have Giles from OMT Training. This podcast bridges the gap between science and practical application. So whether you're a physio, a chiro, osteo, an exercise phys, strength coach, or just like passionate about human performance, we've got you covered with this podcast. Each episode, we're going to dive into evidence-based strategies, cutting-edge research, and real-world insights to help you elevate your practice and empower your clients. The point of this podcast is to really bridge between what would be exercise rehab, sports performance, sports science, and manual therapy. But today we're going to do a little bit of controversy. Obviously, we published an article on the Y-strap. If you haven't read it, I'll post it below in the show notes. But you've probably seen some pretty crazy viral videos, chiropractors or other professionals, maybe osteos, maybe physios even, yanking on patients' heads, triggering loud cavitations, dramatic reactions, girls in yoga pants, and millions of views. But what does the science actually say? Is the Y-strap an effective spinal decompression tool? LVLA, HVLA, which is it? Or is it a flashy gimmick? So in this episode, we'll break down the biomechanics behind the Y-strap, its proposed mechanisms, and whether the research supports its use widely or generally, clinical use. I will also discuss our own findings from a recent study that analyzed its effects on the cervical spine, neurological function, and patient outcomes. So if you've ever wondered whether the Y-strap was a game changer or a complete, utter waste of time, or somewhere in the middle, stick around because we're going to talk about it. Regardless of where you are, if you're in the train, in the car, if you're on your way to uni, if you're on your way to work, we're going to aim for around 30 minutes. So if you put it on 1.5 times speed, which I do, well, maybe while you're on the treadmill, you're getting in your cardio, it shouldn't be too long. Okay, Giles, you're first author on the paper. I want to hear your thoughts. Firstly, why write this paper? Obviously, me and you wrote the paper together, and a few other authors, Jamie and Rob, shout out. Firstly, tell me why you wanted to explore this topic in the paper, and then lead us into a little bit more about the Y-strap.
So one of the reasons why I was interested in initially broaching the topic was purely because of social media. So over the last, I would say last 10 years, you've seen this steady incline in more provocative videos, more viral videos. People seem to be trying to get a one-upmanship on each other. And the Y-strap seems to be this natural progression within this manipulation genre because it can be seen as quite aggressive, large, high velocity, high amplitude tractions. The almost sensationalization of this modality, these amazing before shots, after shots, these amazing claims. And I've got to be honest, as a manual therapist, as an osteopath, treatment is not as sensationalistic as it's proposing. Treatment's a long process. It's good clinical thought process. It's good diagnosis. It's good rehab. It's good exercise. It's a long, slow process. And there seems to be this idea that Y-strap is this game changer in physical therapy, one technique to cure all ills. And it's just frankly not true. So that was where my interest on the topic came from.
Tell me, why is it important that we don't fall into this notion that there's a one size fits all, or there is this one technique that rules them all? I think in the video on social media you said, look, this is not Lord of the Rings, this is not Harry Potter, there's not one to rule it all. And you even mentioned a concept in a paper that discusses mono-interventionalism, which is a very interesting topic. Do you want to expand on that?
Yeah, so the concept of mono-interventionalism is the idea that you have this one technique, and that one technique is going to fix everything. And the problem with like a mono-interventionalist ideology is that you become fixated on that one applicator, and you don't really appreciate that patients can respond very well to other modalities, whether that be mobilization, soft tissue work, acupuncture, exercise, a whole plethora of different techniques. And let's be fair, when you're treating a patient, if there was one technique that was the best one out there, we would all be doing it. Every therapist out there, you wouldn't have any other type of techniques. It would just be this one technique. And also, just because something is popular doesn't mean it's evidence-based, doesn't mean it's valid. That was also one of the thought processes around it. And one of the highlights that we did with the research was the idea, just because something's popular doesn't mean it's valid. In the Victorian era, they would blow tobacco smoke, but with a big long copper pipe up the patient's bum. And that was there to cure all sorts of MSK problems. And that was very popular. It doesn't mean it's a valid technique.
No, and I mean they believed in the humours, the four humours.
Yeah.
They believed in obviously drilling into people's skulls.
The problem is this popularity gives patients the wrong impression, and it gives new graduate students the wrong impression. They believe that that's the most appropriate way to treat a patient, and the patient believes that's the one technique to fix all their lifetime of injuries and ills, which certainly is not the case.
It's very easy to buy into it, I suppose, if you're a new grad or you've only been in practice for a short time, and one of the things you're opening every day is your phone, you're opening the Instagram app. That's how you connect with people throughout the world. That's how you connect with your colleagues and your friends around the world, especially when it comes to this kind of small bubble of rehab. The rehab world's quite a small, tight bubble, and a lot of people know each other, and you're opening these videos, and what you're seeing is this type of behavior rewarded through views. That's something that we should also touch on, is social media is rewarding this type of behavior because it gets clicks, it gets eyeballs. It doesn't, again, mean that it's valuable. It certainly doesn't mean that it's clinically valuable. I know when it comes to the Y-strap, we really wanted to contrast the difference between that and other modalities, contrast the difference between that and what would be an HVLA or an LVLA, and what we would refer to with the Y-strap as a Y-axis, so a single plane maneuver, that would be a high velocity, high amplitude, so it'd be like an HVHA. When it comes down to some of the biomechanics, do you want to touch on a little more about that so people can have an understanding? If we were to, let's not talk about, let's put LVLA, so mobilization, articulation, to the side for a second, but let's compare it to traditional potential cervical techniques, whether they're rotary, osteopathic, even Gonstead. We've done it all, right? We've discussed it all. We've published research on it all. You've got papers on it all. There's a book coming out on Gonstead. You've got 6 other published books, this and that, right? So let's look at the Y-strap versus what you'd ideally would be more specific, short lever, HVLA to a cervical segment.
When you're looking at the two techniques in its sort of simplistic format, one is predominantly using a flexion, side bending, and rotation, multiple vectors to create a rotatory thrust, which is the conventional neck manipulation. The other is a Y-strap, Y-axis distraction, where you're pulling point A from point B with rapid power. With the traditional cervical manipulation, what we're doing is we're using vectors to lock to the barrier. We're finding the barrier in that joint space. And that's the point where the joint sort of automatically stops, because any further movement would potentially stress the soft tissue structures around it. And that's why we use these intricate little movements, so that when we do apply a thrust, it's over a very, very short distance. And the only way you get that short distance and you get that reduction in potential compromise of the surrounding structures is by using these very precise little vectors. That locks the joint out, reducing the space. Without those vectors, you end up having a very large sort of space where the patient or the therapist is going to have to apply a large amount of pressure to basically get to that barrier point where you're going to cavitate the joint. I think with the Y-strap, it is basically not utilizing any of the vectors. It's pulling point A from point B. So not only are you going to get a cavitation of the joint, but you're also putting tremendous amount of stress into the surrounding soft tissue structures, potentially compromising the vascular structures, the neural structures. And I then look at it via risk versus the rewards. If both outcomes, both techniques achieve the same outcome, why would I not choose the technique that's the safest, that puts the less pressure into the soft tissue, that reduces the pressure on the ligaments and the tendons, that's more comfortable for the patient? So although the two techniques will achieve the same outcome, they're done in so different a way that you've got to weigh up this idea about risk versus reward when you're sort of utilizing them, if that sort of makes sense.
Yeah, and to add on to that, when we discuss specificity in the paper or even around this topic, some people will respond and be like, well, hang on, you guys also talk about how manipulation or certain manual therapy techniques are not specific based on some of the research that we have, and we kind of understand that to be true. However, I would just like to make a distinction that we're often talking about specificity within the context of a specific intervention or treatment that you've been able to get to through a very comprehensive assessment, history, and clinical rationale. So that's the differentiation. We're not necessarily saying that you can move a bone back into place, which we know is not true. We're not necessarily saying that the distal aspect of your index finger can go in and contact the superior lateral aspect of the spinous process and move it just so much that you fix the person's life forever. We understand that specificity is likely not achievable based on the research. But when we do discuss specificity and the importance of being specific, it most certainly comes down to a diagnosis. And I think that's important to state because we're in the murky waters when it comes to MSK rehab, where people have stepped back and they've said, well, a lot of things are non-specific. So they've become so hyper-detailed that they'll step back and they'll say, hey, then everything has to be non-specific, which is something that I often like to challenge. So I just wanted to make that clarification if people were wondering. But with the y-axis, I have seen people... Majority of the time, you're seeing a snapshot and you're seeing someone just kind of do the treatment. If you go on YouTube, you do a little bit more work, you can see some practitioners do have an assessment protocol. But what I find is that they will document findings and then they will treat those findings with their short lever, lateral bending rotation component, more traditional type HVLA. And then once they've cleared those restrictions that they've deemed to find, they'll then put the Y strap on and finish it off with one last Yahoo, just one last big party wave of yammy, So where does that line up? If we take the fact that we just don't know, the unknown, the lack of research, the lack of understanding what we currently have, even thinking about it from that point of view, that does breach what we would consider that rule that we like to follow, which would be, hey, make sure that your interventions are specific to a very well thought out assessment. Don't just give someone the flying seven. I know in chiropractic we joke around, you give someone the flying seven. It's like side posture, thoracic, cervical. Why go through a process of trying to be specific with your intervention only to finish it with just one big pull?
My sort of thing as well is surely there's been more than a handful of extreme or bad cases come from doing this type of manual therapy as well. Even just when it comes to like insurance claims, it can't be long before insurance companies come knocking on the door too in regards to that. Like that's what I was sort of thinking about, is more like how are the clinicians or practitioners willing to, like put their own like name or practice on the line when it comes to doing these type of manipulations. But like I'm more in the mindset of like you're assessing and you're trying to achieve the same effect with a different technique. So for someone like me, it could just be like a low-grade mobilization where you're just trying to provide sort of gentle traction to the cervical spine anyway and take sort of the same effect out of it like Giles touched on before. So, yeah, it's very risk to reward. I'm on the safer end for sure.
I mean, at the end of the day, what are we trying to achieve? What are we trying to achieve with manual therapy? Are we trying to fix the person with manual therapy? Because that feels like we're going back down the mono-interventionalist type thought process. Are we trying to get them to a point where they potentially have a greater capacity or a functional capacity that they may be able to do rehab better and get them into a off-ramp into exercise rehab, which I think is where the research supports? I know for myself, all three of us sitting on this podcast do things a little bit differently, but we converge on the main things and the important things. That's because what do we converge on? We converge on the evidence-based practice. That's what I like to believe anyway. I'm sure there's little differences here and there. Personally, I love working, and I know there's other practitioners like Kelly Starrett that do this, but I love working with what I like to call SAMT, self-administered manual therapy. So I love taking the understanding of research, the understanding and depth of what we know and the outcomes we can achieve with hands-on manual therapy and taking that through the lens of what would be exercise-induced SAMT, so self-administered manual therapy. I know you, working in the clinic, Luke, you do a little bit of everything. Obviously, Giles, you travel the world, you see patients, you're very, very skilled at manual therapy. So for someone like yourself that teaches, you're teaching people all the time, you're seeing patients, not just patients, but students come in hungry to learn. What do you say to these people when they turn up to a class and they just want to learn how to Y-strap? Because it must happen, right?
Oh, no, it happens all the time. I think a lot of it's down to the education of the student, the discussion around the realities of clinical practice. And what I sort of explain to them is good treatment, like good rehab, is really, really boring. It's not social media warranted. It's foundational techniques. It's about good, solid foundations that you then build upon. Good therapy, good rehab, good exercise tends to be quite boring. And the reason why it's boring is because it works. This sensationalization, this sort of bizarre showmanship of manual therapy, that people are walking in and having an intervention and then throwing their crutches away and being able to see, is an absolute myth. And I'm sort of trying to explain to students that sometimes young graduates feel very disillusioned. They feel very lost. They feel like imposter syndrome. They don't feel like they have the knowledge or the skill to get these patients better. And all the people on social media seem to be fixing everybody, from someone with back pain to someone with, I don't know, someone who's recently died. They can bring them back from the dead with a Y strap. They can cure baldness. They can Y strap your autism away. It's phenomenal. And talking to students over the weekend, they were saying to me, we feel lost. We feel like imposters. Why are we not having these dramatic results? And I'm saying to them, you're not having dramatic results because there are no dramatic results. It's boring, repetitive, slow progress. This idea of this sort of, I don't know, crescendo of pain-free movement once you do this one technique is such a misconception. So yeah, there can be a tendency of young students and new grads and patients expecting a magic treatment, a golden bullet, a one technique to cure them all. And I'm sort of, a lot of it is down to lowering expectations of students and telling them it's not exciting stuff half the time.
Okay, so tell us more about this email, because there's one interesting thing that I think really kind of supports our article, is the fact that even the manufacturers do not necessarily, it's pretty blanket, black and white what they say, isn't it?
Yeah, so about 2-3 years ago, I contacted the manufacturers of the actual Y-strap, and I asked them to provide me with some research. I said I was a training provider. I was interested in any research, because they were stating that a Y-axis manipulation was far safer than a rotary axis manipulation. So I emailed them and said, well, that's very interesting. Can you show me the research that validates this statement? Have you got any research? And they pinged me a message back saying, we have no research to provide you. And I said, well, why are you saying this is a safer technique for spinal manipulation? And then I got an email saying the Y-strap is designed for gentle spinal decompression. Okay. It is not designed for spinal manipulation at all. And what therapists use it for is outside of the scope of the clinic or the company, sorry. It's not down to us. If people are going to use it to crack people, that's down to them. But we don't design it for anything other than gentle spinal decompression. But it's a bit ironic because the videos on their websites promote HVT manipulation. So, the email says one and the social media says something different. The question is, can you achieve the same neurophysiological outcome with mobilization? Yes. Could you achieve the same neurophysiological outcome with soft tissue techniques? Probably yes.
Without
could
a cavitation?
You achieve the same?
Yes.
Could you see the outcome with dry needling, with exercise, with movement, with maybe some CBT, maybe some gentle, I don't know, movement patterns? You can achieve the same outcome with a plethora of techniques. So why go for the most invasive? Why go for the one that theoretically compromises the structures more than anything else? Because I don't know what the vascular structures are under the neck. I haven't got a Doppler. I don't image the patient. So I'm guessing about their cardiovascular health. I'm guessing about the structural integrity. But if I can achieve the same outcome with a technique that doesn't even stress the structures, why am I not choosing that? And that's the discussion. Why a therapist and patients not, saying to patients, look, shared decision making. The patient needs to understand what technique is being applied to them to consent to that technique. Without consent, it's an inappropriate treatment. So the patient needs to know what the risk is and what the options are. Can you achieve this differently? I mean, I'm not going to go into surgery without looking at all of my options. So you should be giving the patient options. You have neck pain. I could rub you. I could needle you. I could mobilize you. I could manipulate you. Or I could try and take your head and throw it across the room. What would you prefer? There doesn't seem to be any shared decision making or discussion. It just doesn't.
In sports science, we kind of talk about that in regards to the minimal effective dose when it comes to implementing some type of training. And it's interesting in this situation, like you said, if you can achieve that neurophysiological outcome from a different intervention that is potentially safer, why not? Then that's an avenue you can look down to do. It does come down obviously to where you're trained and what you're trained in as well. So obviously people kind of have their wheelhouse, they kind of have their tools of tricks, right? And they're going to elicit their neurophysiological outcomes or changes the way that they feel most comfortable. But I just think when it comes to something as under research, the lack of understanding that comes from putting a strap on someone's chin.
Right. Not everyone can crack someone's neck. Okay. Not everyone can do it. It needs practice. It needs an understanding. It needs a little bit of anatomy. People need, but anyone can strap someone's head up and yank it. There's no skill or finesse there. There's no skill. And if therapists are not trained in it, if there's no courses in it, as Luke said, and you do that to a patient, your insurance company is not going to touch you. Your governing body is not going to touch you. That sort of legal process is going to turn around and go, where did you learn this technique? The manufacturers don't freaking suggest it. So what course did you go on? I didn't. I learned it on YouTube. Yeah. It's a massive problem that people are watching these things and going, well, do you know what? Alibaba, I'll 5'5", and let's just see what happens.
When we looked at all the research and we said, okay, at one point in the article, I decided I really wanted to see what the research was on traction. And some people may think, well, that's not related to the Y-strap directly, but it's like, okay, the manufacturer said that this is kind of, is not designed for HVLA. So you take a leap of logic. There's obviously slow articulations, LVLA, this and that, but traction, when we look at the research, and I know we've touched on this briefly already, there tends to be a moderate amount of pretty solid evidence showing that, for the cervical and the lumbar, for herniations, etc., that some type of traction, slow, rhythmic, controlled, seems to be effective. I think when it comes down to it, we want to be thinking about control, and when it comes to a high velocity movement, as velocity tends to increase, control can often decline. And I think that's why, for example, someone like yourself, Giles, you spend so much time trying to teach people how to do an HVLA safely, because you're moving quickly, and that's why you have the short lever, that's why you have the rotary and the lateral flexion, and you have these components. You take it to that paraphysiological space, like you said, and then to take them over the line, it's just such a small movement. It's not something that's going to be this massive, taking uncomfortable click and crack like you can see with maybe some of the Gonstead movements. We also published papers talking about the cavitation, and we concluded that the cavitation is not required. We also published a paper looking at manual therapy, HVLA versus LVLA, pretty much is what we looked at, right?
Yeah.
And the similarities between those two. And I have to be honest, when I started looking into the research about LVLA or articulation or more slow rhythmic stuff, and I started discussing it with you before we even read our paper, it was actually quite shocking. It is that kind of mono-interventionist ideology where you think one thing can do everything. And so if there's one thing I want people to take away is go read those papers, because if I knew that when I was back then, man, it would have really opened my eyes to so much more. And if you are in a situation where you're being taught that one thing can do everything or fix everything, there is good information out there that can debunk or at least challenge that. And we've tried to put that out there, myself and you, Giles, and even me and you, Luke, with our imaging paper, because it's just not really the reality, is it? We can't see this in the clinical guidelines. The clinical guidelines don't support it, they don't have it. So it's impossible for us to sit here and say, we're evidence-based, we're following clinical guidelines, we're following the evidence, and then go and yank someone's neck with a Y-strap. It's not in the clinical guidelines. The manufacturer doesn't support it. So when it comes down to it, even if you think it's a good idea, erring on the side of caution is definitely something that I would suggest. To conclude the podcast, I wanted to know from either of you, number one, would you Y-strap a patient? Let's say this, have you or would you Y-strap a patient? And number two, have you or would you Y-strap a family member that you care about? I'll say care about. And I'll go with you, Luke. We'll start with you. Go.
No and no. Simple, straight answer. It's just, again, everything we discussed on the pod today goes against it for me, and it's a complete shotgun approach. So for me, it's just like I'm not willing to put myself on the line, my patient on the line. And again, I already pay enough for professional indemnity insurance. So if something goes wrong, it's going to be 3 times the amount. I'm going to have people come and hunt me down. So again, unless it's on your algorithm on Instagram, and that's all you're seeing, I can see why these people, sort of go down the line and question whether they should be doing it or should not be. But for me, it's a hard no. So yeah.
Well, you sum it up very, very nicely. No, I've never used it, and no, I wouldn't use it on a family member, to be honest. Look, the reality is nothing is magic. Nothing. There's no one thing that will treat and cure everything. It's a myth. This at the moment is the Y strap. In 2 or 3 years, it'll be something else. Please critically think and challenge. Don't just follow the crowd. Yeah, just because it's popular doesn't mean it's valid. Anecdotal evidence doesn't mean it is scientifically relevant. So just think and don't be a sheep.
And for me, I haven't used it, and I wouldn't use it either. I would, however, like to explore a conversation in another podcast with you, Giles, where we discuss if more force is ever necessary and if more force and an adjustment is ever beneficial. So I don't want to get into it now, obviously, but that is something I'd like to talk about. In regards to as we close, for the people that are listening that are new grads and they're feeling confused and unsure and they just don't know what the hell they're doing, what words of wisdom would you give those people?
Yeah, it would definitely be just trying to hunt out and look for the pioneers in our field, the rehabilitation space. People who, walk the talk, people who are constantly putting in the work, teaching manual therapy around the world like Giles, people who are constantly challenging their own ideals and beliefs. We don't always get it right, but as long as you're willing to change along the way when sufficient research and evidence pops up, that's a very green flag for me. And yeah, stay away from the social media warriors online. People who are constantly bagging, putting people down, pushing their own narrative and bias, just for views and clicks. So those will be the couple of key points I would recommend for new grads.
Nice. Giles?
No, I think you sum it up. I mean, the reality is you need to critically think. You need to be able to change your mind. You need to admit when you're wrong. Don't look for the easy route. Read, and just don't be afraid to be wrong and learn off other professionals, and don't sort of buy into the hype. And we all feel exactly the same. You're not alone. Don't worry about it.
Yeah, for me, it's look up the Dunning-Kruger effect, understand the Dunning-Kruger effect, and be aware that you're probably at the beginning of the Dunning-Kruger effect. But what we want to do, obviously the goal is to learn, be humble, show some humility, be respectful on social media. I'll leave you with this question, which would be, when's the last time you changed your mind? Because I feel like that is a pretty relevant question. It's very easy to get into the same echo chamber. If you're a new grad, that echo chamber was likely your university, or it could be these self-appointed gurus that are on social media. If someone is talking, I call it the floating head. If someone is constantly, their head's floating on Instagram and they've got someone behind them and they're constantly just critiquing others, telling you what you can't do, telling you what doesn't work, and they're bringing you no actual ways forward, no ideas on how to actually treat. As Dr. Locke says, they're not bringing you solutions. If they don't have score or any wins on the board, turn around and find someone that does. There are plenty of people like that. I think the most important thing though is don't be a dick. Be kind, stay humble, and be eager to learn. And that's probably the best thing I could say. Any other thoughts from you guys?
Mate, it's all good for me.
Awesome.
All right. Well, thanks for listening to the podcast, and we'll see you next time. Each episode, we're going to dive into evidence-based strategies, cutting-edge research, and real-world insights to help you elevate your practice and empower your clients. Okay, so welcome to the Rehab Blueprint Podcast.